So, hey everybody, I'm Ellen. I need no introduction. So, I am super excited to come to you today with my new friends. Equity and inclusion in healthcare has been a passion of mine for some time. And I feel so grateful today to have the opportunity to bring together a group of incredible women who are on the forefront addressing these issues in inclusion and equity in healthcare. We want to talk about this. We want to get other people talking about it. And we're here to kick it off. So I'm with my partner, Sheena Williams, who is a cardiac telemetry nurse out of Philadelphia. And Sheena and I wanted to come together and start these conversations. So she's going to introduce our doctors today.
All right, so first of all, to introduce Dr. Uche Blackstock, funniest thing is that I saw one of your YouTube videos and the first thing you said in one of the interviews was, I'm sick of this bullshit. And I was like, yes. That way, if anybody curses, we're all good. So this is Dr. Uche Blackstock. She is a Yahoo News medical contributor, and she's the founder and CEO of Advancing Health Equity. And then we also have Dr. Callie Cyrus, who is a community psychiatrist in DC. She's also a diversity strategist, and she's the assistant professor at Johns Hopkins Medical Center. And then last but not least, we have student Dr. Tumishe Fawole, who is a student at NYU. We're so happy to have you guys. We appreciate you guys for being here.
Thanks for having us.
Thank you.
Okay, so I'll start with the first question. Dr. Blackstock, and whoever else wants to answer, feel free. How inclusive is the healthcare industry?
So the healthcare industry, medicine, and all the institutions affiliated with it have a lot of work to do with regards to equity and inclusion. So we know that the number of Black physicians overall is quite small. We have 4% of all physicians are Black, 2% are Black women. And we actually haven't seen those numbers budge for over like 40, 50 years. And so, that is something that's incredibly concerning, but I think that speaks to a lot of the structural barriers that are there. So we have a pipeline issue between kindergarten and 12th grade where, we don't put a lot of money in this country towards education. So that's one thing. So we have kids graduating without a solid quality education, but we also don't have those kids being exposed to healthcare professions as an option, right? And then once they are in environments like college where they're pre-med or they ultimately get to medical school, those environments themselves can be pretty inhospitable. They have to deal with microaggressions, discrimination, not just from faculty, but from also their peers. So it's almost as if as every step along the way, that there are barriers that Black Americans have to encounter to even become a physician, and then add on to that the financial constraints. Going to college and then going to medical school is a lot of money. People graduate medical school with six-figure debt, over $200,000, and so when you think about which families can afford that, and you think about the racial wealth gap that we have in this country. Black students are really at a disadvantage in being able to afford to go to medical school. So there are a lot of different factors, that I mentioned that are really leading us to a situation where we have very few Black physicians, we have, few Black medical students. And I think, we know that's one of the reasons why we're seeing the racial health inequities that like the Black maternal mortality crisis that we're seeing in this country.
I might actually just pick up where you left off. You're talking about pipeline programs. I wasn't even really going to talk about this, but so I'm the first person with essentially a graduate degree in my family, of course, the only doctor. And I had the benefit of being in a pipeline program when I was 13 that essentially gave me summers of biomedical research. And so I knew coming in that I wanted to be a doctor, and multiple times almost gave up because it was just so difficult. No one really understood in my family what I really needed, being in a lot of these institutions where, I didn't have a lot of the social capital that everyone else did. And then I think when I actually did become in residency, become a faculty member, you spend your whole life thinking of yourself as part of this community, and you talk about inclusivity. and you realize that you're not actually really included. So even when you do sort of jump over these hoops, you get to be in a community, and depending on, I happen to be a multiple minority person. So as I'm cisgendered, but I'm queer and I'm like butch looking, and also Black. And I feel like, so being inclusive, so imagine having to find a community that fits all of these identities,
Right.
and you
Right.
feel safe. And that's also, I think, part of when I think of inclusivity is like, do you feel safe and included? And unfortunately, if there's only 2% of Black female faculty, how then are you supposed to feel
Right.
included in this? There's not a mentor who looks like you to help sort of usher you into this community. You feel isolated. Who do you go to at the end of the day to talk to about some of these issues? The sense of gratitude, which is, you've gotten to this point. How do you sort of pave the way for other people who look like you? You always sort of feel like you're trying to do for everybody who looks like you, like the shoulders of all Black people or all Black women are on you. And then you can imagine that you inevitably fail, right? So there's no way that you can do all of that and exist and take care of your mental health. And so I think that everything you're saying, Uche, is, starting from, the pipeline to actually becoming
Right.
a physician, and how that actually,
Right.
yeah.
Yeah, and actually, one thing I didn't mention is that, so unlike Callie, I'm a second generation physician. My mother was a physician, and she had a very different upbringing than I did. She grew up in poverty. She was the first person in her family to go to college. She had born to a single mother, 5 siblings. She really struggled significantly. And you would think even me seeing her as a physician would make things easier, right? But I still had imposter syndrome, right? Because of all this other messaging that you get that you're not enough, right? And so I only think about people who didn't have that that role modeling, how difficult it's for them, if it's even hard for me. And then, Ellen, and Callie and Timiche also know, but Sheena, I wrote a piece, an op-ed in January about how I'd left academic medicine because after being there for almost 10 years, I was doing diversity, equity, and inclusion work, but I was silenced. I was muzzled, and we were seeing these, microaggressions and even racist and sexist, interactions happening. And, that's even for me as an associate professor having to deal with that.
Well, I actually did look at one of your interviews, and I thought it was amazing, something that you said in there when you said they create these committees and boards for us to be a part of for inclusion, but they don't really want you to actually do anything. They want to say that they got the committee, but then when you actually start to actually make changes and speak up and talk about it, then it's like, wait, no, we didn't actually want you to do anything. We just wanted you to pretend and kind of be there and be Black, and that's all that we wanted.
For them.
Yeah,
for them.
Right.
Not for you, not for your community, for them.
Right, and it's basically like you're a figurehead. So I was in this diversity role, but I really wasn't empowered to do anything, even though I had all of these, these big and grand ideas, things I wanted to see happen, structural change, but I wasn't empowered to do it. And in fact, I was silenced and censored. And so, and it's not just that institution. A lot of institutions are like that.
Yeah. And they do it subtly. It's the microaggressions. It's the small things. It's the different ways that they make you feel like if you say something, that it's going to come with something. It's not just going to end there. It's more to come.
Well, yeah. After a while, I was scared that I was going to be told to leave.
Right.
And told to leave because I was speaking the truth. And so there was that, confusion in my head because I said, I'm just doing what's right. I'm just speaking the truth. Right. And so why am I getting in trouble for this?
Right. And I think that, there was nurses at one point in time that decided, okay, you actually don't get a blood infection after 3 days. You get a blood infection after 4 days with an IV. They did the research, they figured it out. And now we changed IVs now can stay in for more than for 4 days. That started with a nurses station conversation. That started with people talking amongst each other and then saying, this doesn't make sense. How can I make it make sense? Now let's do the research. Now let's study and let's change this theory or this practice. How are we supposed to use evidence-based practice when all the evidence is there, but we constantly keep ignoring it to make other people feel comfortable? How are we supposed to get there?
I know. So I'm going to interject here and I'm going to punt it to Tamisha, because I feel like one thing that saved me when I was faculty is I was always kept going by the medical students. Just like so invigorated by how much activism, especially when you're like a generation that's trapped in between, you know, the senior leadership, and then you have, you know, people who are younger than you or more junior. And I would love to hear what it was like for you as a student, what it's like, because currently you are a student, right? A medical student. Like, how do you deal with this when you see your mentors like Dr. Blackstock leaving, and you hear us talking about, you know, inaugurated into this medical system as a physician?
That's a great question. So I think for me, my style has kind of changed. So I came in and I was student council president for a while. So for me, it was easy to kind of like leverage these conversations because I was meeting with these faculty members and these administrators already. But I think that the one taxing thing is that, you know, as student council president, I had the ability to just plan fall formal and spring formal and like, you know, throw some things at an alumni ball and leave it. But like, I'm passionate about financial aid. I'm passionate about mental health services for like, you know, students underrepresented in medicine. I'm like passionate about getting, you know, several things changed. So I think it's hard from that standpoint because like, you know, you're trying to, you know, push forward this, you know, you're trying to push the envelope on what the institution is doing, but at the same time, you're still expected to score super high or like, you know, go through your clinical rotations in Excel while your peers are just wondering or like concerned about which antibiotic to use for which UTI. And you're like meeting with, you know, deans to try to figure out how you can get language changed. So, I mean, it's great that like, I think especially the community that I've fostered around myself is very supportive, but I think it can be very taxing when you feel like the onus for pushing certain things is on you rather than like the institution itself, if that makes sense.
Right. It's a lot of pressure because you're not just expected to just be a physician. You know, you're expected to be the physician. Like you're, like Dr. Callie said, is like you're kind of like paving the way for others. It's so much extra pressure, so many extra things that you're worried about that someone else is like not even a thought in their head. And that's the thing, is that if we communicate these things better, then there'll be better resources for everybody to feel inclusive when they're in these type of fields. So,
Tanisha, do you feel like you have a group of friends who you can rely on? Have you been able to gather any little tribe to feel like you have each other? Or
I feel like at least in my class, the other Black students in my class, like we're very much like a unit. So I think not just in my class, but like the other like underrepresented minorities at my school, like are really very much like a cadre. So I feel supported in that sense. I don't feel like I'm the only one trying to do something. I think that we all like came here because we're all passionate about making a certain type of change. But I do think that sometimes it does feel like a bit of a Sisyphean task because you're like, oh, we're almost there. Oh. So I think that is, yeah, there is support, but it's still like, you're still kind of swimming against the current, if that makes sense.
And Callie, how does, you know, the psychological toll of having to deal with this kind of pressure on top of the academic pressures, how would that affect a journey?
So, I mean, the first thing is that it affects your journey in that you know you have to get through it. And I think that eclipses like as you're actually suffering, that you can actually sort of process and acknowledge how much you might be suffering. So even if your circumstances, like you might be the only in every single class or in every single sort of rotation, you still know that you have to work twice as hard, is like the sort of the way to think about it. And so what I think that does, at least psychologically, is that, and I can see this with myself, so I see how it's affected my journey, is that I'm so out of touch with when I'm actually upset or alone or scared or something. I've had to just keep on getting to the other end. And I mean, this is after someone who's been, and I've been in these kinds of institutions forever, right? So many of us are pedigreed if you think of it in this way. And now that I'm in a pretty safe place in terms of my professional life, but I find that I still have, I'm going to call it like little t PTSD from my medical training, honestly. So, you know, from the isolation, from the lack of mentorship, from having people who I can kind of resonate with when things like microaggressions or racist sort of discriminatory acts are happening to me. I've just learned to internalize it. And so I've gotten to a point where when things happen, it doesn't even, I don't even let it faze me until it catches up with me later. And so you essentially, you have to become this like magical minority is what people say. You have to be able to do it all. And what I think it does is it sort of erases you to be able to be a well-rounded human, because your goal is always looking towards, you know, the journey, the end of the journey, right? Once you get into, you gotta get into medical school, then you gotta get into residency, then you get a faculty job. And then some of us who get faculty jobs, like Dr. Blackstock and I, you get there and you're like, what is this place? People are gaslighting you, right?
I know,
People
I
are,
know.
you know, demeaning you. And you're like, this is a dream I've worked to. So, you know, Uche and I talk about this since leaving academia. It's like life was really hard in academia. You know, I got my dream job after I finished residency for psychiatry at Yale, and really got this job on paper that was remarkable. And within 3 months, I knew it was time to go. These are people that I'd known for 4 years already. They were my mentors. Just, you know, doing things like denying that conversations ever happened, you know, not giving me administrative support when I asked for it, when I was clearly teaching and mentoring and doing all this. And I see it now, and I'm pretty frank about my mental health. And I'm at this point where I don't interact with as many people who don't look like me anymore. Like I'm nervous in some professional circles. Like I'm not quite myself. And it's hard to say that I was like traumatized in some of these settings, but I'm realizing like how much emotionally I shut down just to get through the journey. And then you get to the end of the journey and you're like, WTF? And I'm trying to do something.
Like last year, you remind me, last year I was promoted to associate professor, and I think I was like one of 3
This is
Black
like a
women.
feat, by the way, to be promoted to associate professor.
And then I realized I had to fight for that promotion. Like I literally had to fight tooth and nail, even though everyone had said, "Oh, Uche, you're a shoo-in," right? And things did not happen the way that they were supposed to be. And I couldn't help but think that this was because I was a Black woman and the work that I did was not being appreciated fully the way it should have been. But the fact that I walked away from an associate professor position and half my department was looking at me like I was crazy, but I had had enough. I wanted to be in an environment where my voice was heard and appreciated, where my work was appreciated and valued. And it just wasn't in this environment. And I wasn't the first, and that's the other thing, and Tamisha knows this, like I wasn't the first Black woman to leave like this. There were a trail of bodies, so to speak.
Well, I think
that came before me. Go ahead.
I think that one of the huge things that both of you said was that you left dream jobs in very short amount of time. And you know what's funny is that other people see it as a short amount of time, but truthfully, your journey has been so long with this that by the time you got there, you ain't had no more left.
Right.
Like seriously, because people think like, oh, she was at that job for 3 months. She was at that job for however much time. So like, how could she have possibly gone through enough? But no, baby. We've been going through this for a long time. So like, that was just the straw that broke the camel's back.
Right.
We've been having these struggles and these issues and these problems. And you get to a point where you're just like, enough is enough. You're doing so much. And like Tamisha said, you're already dealing with the stressors that are normal, the normal stressors of doing your job. So then to have cases of harassment, cases of being silenced, cases of feeling like you're inadequate, cases of feeling like you're judged more harshly than other people, it hinders you from doing your job, and it makes you almost feel like you're operating from behind something. Like I'm showing you a different person than who I really am because I literally am not allowed to be who I am.
Well, that's the other thing. And we talk about like code switching in different environments, but you feel like sometimes you really can't be yourself, right? You can't really say what your truth is or how you really feel because you have to worry about the repercussions of that, right? You know, I mean, there are even some things, I don't mean to put her on the spot, but that Tamisha is probably not going to say fully because she's still a medical student, right? And because she has to worry about what are the repercussions if she says something that the school's not happy with.
And this was a big concern of mine when I thought about this panel. I really wanted to make sure that all of you felt good about this and I wasn't putting anybody
Right.
in an awkward situation. And why I appreciate even more all of you coming and speaking. And you know, what stands out to me is just what Sheena just said, is like, how are you supposed to give 200% to your patients or to your students, you know, when you're dealing with all these other pressures? You know, it's just so unfair. And so systemically, Uche, can you speak to, clearly the system is set up to be racist. And can you speak a little bit about how these systems have been set up and what ideas maybe we could implement to start to break those barriers down?
Yeah, you know, it's so interesting because I think especially with healthcare and medicine specifically that the racism is so embedded. Like it's from the beginning. Like when I do talks and trainings for my organization, I talk about a doctor named J. Marion Sims, right? He's considered the father of modern gynecology. He created the vaginal speculum that many of us have used on us when we go for our annual gynecological exams. But he also was a slaveholder, and he also experimented on Black women who were enslaved, using these very painful procedures, right? And so what we have is this really deep, horrific history of how medicine has essentially abused and exploited Black communities for centuries, right? And so, you know, I talk about J. Marion Sims. I also talk about Tuskegee, right? The Tuskegee syphilis study, where, you know, you have men from the 1930s to 1970s being enrolled in a study by the U.S. Public Health Service. They were told they had bad blood, but they actually had syphilis. And a good number of them were not treated, even though a known treatment was available, penicillin. And many of them ended up developing advanced syphilis. They ended up transmitting syphilis to their partners, and as well as babies had congenital syphilis. So, you know, this is not going to change in overnight. It's probably not going to change over a few years. But I think that healthcare institutions have to be more intentional. And, you know, we hear about anti-racism a lot. You know, I think we have to really, like we're doing now, talk frankly about what racism does in terms of it's a sickness. It makes people sick. So all of the racial health inequities that we're seeing, the high Black maternal mortality rate, that is racism, because there's no biological reason why Black women should have a higher maternal mortality rate than white women. There's no reason. And all of that is because of practices and policies over the years, like redlining, right? Redlining, the GI Bill, even.
What is redlining? I'm sorry.
Sorry. So redlining is this federal policy in the 1930s that assigned grades to different neighborhoods throughout the country in cities, and basically A, B, C, or D, and you got a poor rating, a C or D, if your neighborhood was mostly Black or some sort of ethnic minority. And you got an A or B if it was mostly white. And the significance of those grades were, if you got a higher grade, you were more likely to qualify for a federally backed mortgage. So you were actually able to buy property in mostly in white neighborhoods, and Black folks and other ethnic minorities were not able to qualify. And so what the interesting part about that, people say, so what does that matter now? When you look at redlining maps, the neighborhoods that have those lowest ratings, and you superimpose present day life expectancy, asthma rates, obesity, those are the same neighborhoods that have, those inequities, right? And so
yes, I thought you were referring to. I thought there was a different redlining specifically for healthcare. So, but right. You're just talking.
But I'm just saying how there are practices and policies even that were sanctioned by our own government that have created these profound inequalities. And so we know that we can actually tie residential segregation to health outcomes. So the policies that enforce residential segregation in the 1930s, you can actually tie it to now, because we know that where people work, where they play, where they live, all influences their health at a neighborhood level, right? And so I think if we do want to change systems, right, we have to really look at giving people gainful employment, opportunities for home ownership, opportunities for quality education, because also what happened out of redlining, if no one is able to buy property in a certain neighborhood, then what's funding the schools, right? And so
sorry, I didn't mean to interrupt you, but
no.
I have a black man who lives in a I guess a affluent neighborhood in Los Angeles, and police knock on his door and say a neighbor saw you walking into here. So, you know, it just doesn't stop. It's like, you are in an affluent neighborhood and your neighbor sees you, and your white neighbor sees you, they're gonna knock on the door and say, I saw a black man go into that house, because there's no black men that live in this neighborhood. That couldn't be.
Right. And it's like you just can't live and you can't exist. And there's this racism iceberg I talk about in my talks where, you know, a lot of times we think about racism as these interpersonal interactions, right? These, you know, people using a racist slur or a microaggression. But really what racism is, the bulk of it is these policies and practices that have been around for a long time that have really disadvantaged Black communities to the point where we've been made sick. We've been made sick. So when we have COVID-19 coming, right, and you look at who's dying, we're dying, right? Because not only do we carry the highest burden of chronic disease, but we're more likely to be essential workers. We're on the front lines in public-facing jobs, more likely to be exposed to the virus. We're living in overcrowded housing. We're using public transportation, right? So it's almost as if these conditions have been created to make our communities sick. And so what's going to be needed is a lot of work and a lot of really intentional funding. It's putting resources, funding back into Black communities.
And one thing that I wanted to highlight that you said is that, you know, these experiments that were done on slaves that were forced surgeries, no pain medications, no, like, you know, terrible things were done to these slaves. The research from that experimentation is what we use for our medical books. So it has to be from the very beginning, because if you're making our practices and our anatomy books and all of these things based on the racist people that did what they did and cruelty and evilness, how in the world, it all goes hand in hand, because the universities are affiliated with the hospitals. So all goes, it is all one big circle of nonsense.
Yeah. Actually, Sheena, that's such a great point, because the HeLa cells, you know, this Henrietta Lacks was a young Black woman who presented to Johns Hopkins with metastatic cervical cancer. Her cells were taken from her without her consent, and they were immortalized. So companies have made billions of dollars off of using her cells. I used them when I was a first year medical student in Harvard Medical School. No one told me where these cells were from. But the interesting thing is they're actually using her cells for research and development for the coronavirus vaccine. And I mean, what her cells have done, I mean, so many discoveries have been made because of her cells, but she's never been fully acknowledged, right?
Yeah. And that's how insidious this all is.
Right.
Here you have this woman whose cells were taken from her, and like trillions, probably more than trillions. I don't even know the number that's been made off of her. And so we're talking about equity and changing systems. I mean, honestly, I think the approach I take is that the money and the acknowledgement needs to be put back into the system.
Yeah,
maybe
I agree.
Come back to the medical system in general. I think one of the points I really wanted to make was maybe around NIH funding, but I think it's about funding in general. So if you value equity and inclusion, then put your money where your mouth is. And so now, if we're thinking about coronavirus, right? Some of it is that we know Black people are getting infected more easily. Their consequences are worse. But think about who's doing the research. How do we study Black people in the first place? I know, Sheena, you were just talking about textbooks, right? Think about who does all the research and who gets all the research money, right? So white researchers are 1.7 times more likely to get NIH funding, and they're more likely to be doing research on like molecular science, when Black researchers actually tend to study clinical issues that have to do with Black people. So if they're not actually getting any money, Black researchers aren't getting money to do research on Black bodies, then how do we ever move the needle forward? If you don't hire Black faculty in these institutions, then how does it ever change? How do you bring up the fact that we in our classrooms need to be acknowledging where these HeLa cells come from, right?
Right.
And so it's then you just end up getting generations and generations and generations of this unacknowledged sort of like racist
trauma,
right? And then we just keep replicating it and throwing lip service to it. So I keep like, I'm not saying your name correctly, and I'm so sorry, Tamisha.
Oh yeah, it's correct.
How do you even, is this part of the conversation where you are?
So
yes.
It's not really as much part of the conversation as it should be. I think a lot of what we discuss, I mean, sure, if you really want to, you can take, an elective that's, does a deep dive into some of these topics. However, it's not really integrated deeply into the curriculum. A lot of times, like in the activist circle, my friends, like, we'll talk about these issues, and there's just kind of no baseline understanding in our classmates at some level sometimes with like even some members of like faculty. And I think that can be kind of hard to push the needle. And I think for me, it's particularly frustrating sometimes because, as doctors, the amount of reading, we do, like, continuing medical education is such a big thing. There's such a knowledge of like the newest, tyrosine kinase inhibitor. However, like talking about structural barriers that affect Black people in particular and other, minoritized communities, like kind of takes a back seat, and people profess their ignorance, which at a certain point, obviously nobody, is perfect. Everybody is continuing to learn. However, for me, I think the most frustrating thing is kind of the lack of prioritization of these issues. And it kind of is relegated to a type of pseudoscience, whereas, the molecular basis is the true hard science, and everything else, that's soft science, that's social. We don't really care about that, which is right. Like, but I mean, of course, molecular science is important, but in terms of like tangible, actual outcomes, like your patient in front of you doesn't care about their germline mutation. They care about how you talk to them. So, I mean, of course, their germline mutation like influences care, but without like a structural understanding of how that patient ended up presenting to you, like you're not really doing anything for the patient. Yeah, and actually, I had a very interesting experience where I was talking to someone not too long ago about, so just to give a little bit of a backstory. So there's a lot of different scores that are calculated in medicine if you have a particular disease. So for example, if you have like heart disease, for example, there's something called the ASCVD score. So basically what this does is it helps calculate what types of treatment would be best for you based on your certain risk factors. However, some of the inputs into that are based on studies that have been proven to like not encapsulate like full measures of sensical health, if I'll be frank. So for example, there's a study that tested a type of heart disease medication, but it only tested it in Black people. So once you then put in race characteristics, a specific medication is recommended to you over another medication only because there was one very, very small study that was only done in Black people. So you're getting a different medication when, again, as Dr. Blackstock said, there's no real evidence for any biological differences in people, but because people have, kind of anchored onto race-based science and bought into these genetic differences instead of thinking about social determinants of health and environmental causes, like we end up having different outcomes and are prescribed actually different medicine based on these calculators.
Wow.
That was a lot.
That was amazing.
That was a whole lot.
Yes. That was incredible.
Yeah, and I want to just ask Tamisha, when you have these moments, because I know when I was in nursing school, they said to me, your mucosa should be pink and your labia should be this. And I was like, my labia don't look like that. So I'm just want to know, when I said that, it was like who you talking to? Shh, don't say that. You shouldn't be saying that. But I'm like, no. This don't look like me. You saying that my gums should be pink when I know many Black people with brown or purple gums or dark blue or whatever. Right. So if you're somebody who, let's just say, because I had plenty of people that were not people of color that were in my nursing school that were from towns where everyone looked like them. So how would they know how to diagnose someone? If I see somebody with blue gums, I'm gonna assume they're cyanotic, you know? So I wanna know, I know my experience wasn't pleasant. I wanna know from you, Tanisha, when you bring up those type of moments, when you say anything, is it a hush moment? Does everybody look at you like, oh, did she say that? Or is it like how does that work for you?
I think for me, I'm actually pretty outspoken.
Okay.
So I mean, I'm just gonna say it, and if you have, I mean, your reaction is kind of, hopefully, like, you take it as a learning moment. It's never an opportunity to dunk on anybody, because that's not productive either. However, like, I'm also not going to shrink myself to make you feel comfortable. So I think peer wise, it goes that way, but sometimes where it's difficult is because when you're like in a clinical rotation setting where you're talking to residents or you're attending, so we're directly grading you, then things get a little, you're a little more reserved, or sometimes you're just like, I'm going to swallow that and move on, which can be, I think, frustrating. But I think among my peers, it's like, this is a good teaching moment. Again, sometimes it's not that I'll have a whole lecture. Sometimes I'll be like, this is a great opportunity for you to read. But yeah, I think it's easy when you have a peer-to-peer relationship. The issue comes when you're lower in the social.
It's a power dynamic, right?
Exactly. Then you're kind of okay.
Right.
I have a story that might be interesting. This is why it's important for not just to be one Black person per class in a medical school. Why needs to be more professors and people who are teaching, because people come from these small, not necessarily small towns, but we come from limited circles, right? We tend to cluster with people who look like us, who we're comfortable with. And so when I would teach this class to essentially health disparities and racism and privilege, like everything piled into one, because they give you one lecture, right, to the medical students. And I would teach it to them, to first year medical students at Yale. And I use clickers when I do my workshop. So there's this, you can ask questions to the audience and they can text in their answers anonymously. And so I would ask them questions like, what's the background of your parents? How many of them are doctors or lawyers? And you could see the makeup of the class. And inevitably I would get to this question that said, would you cross the street? You're walking down the street at night and a tall, dark, Black dude is walking towards you. Do you cross the street? Be honest. And most people would say that they would cross the street. And so we would always end up getting into this conversation about why. And I remember, in terms of talking through the solution, some of that was like, next time you are going to cross the street, ask yourself why you would cross the street, right? Like, why is it? And so many people come from places where they don't have these conversations. They're not allowed to. But I think even like the meta layer on top of this is that one of the suggestions was reach out to these people and not necessarily like put the onus on them, but reach out to them and get to know people who don't look like you. And then I remember, and Uche, Max, he's a friend of ours, that he's a tall Black dude. Essentially after this lecture, he got like 5 emails from his classmates to have coffee. And so
bless their heart.
Because they were literally taking.
Right, because he was the only one they knew. And I tell this story because it just illustrates, it's like it essentially everything we're talking about, right? Is that you don't have space for this conversation. You do have a conversation, but you end up, there's not as many people to have a conversation with. There are not as many examples. I just think it encapsulates so many layers of everything we're talking about. Can't tell you how many students have sent me an email afterwards saying, I'm from a small town, or my experience, I had this X experience happen. Do you have any advice? And it's something that I just wish we were able to actually discuss, but it's hard to find a centralized one. There's educationally, like, how is this included? But then also, I mean, the greater landscape of just, I'm like rambling at this point, but I'm going to stop.
No, Callie, it's actually, sorry to cut you off, Sheena. Callie, it's actually one of my biggest criticisms about this current sort of revolution that we're hopefully experiencing. And I have conversations with all of my Black girlfriends about it, and I've yet to sort of publicly say it because I'm afraid to come off too critical. But I see lots of posts on Instagram, and I see lots of white people trying to do the right thing, bless their heart, but on Instagram is one thing, and blacking out your Instagram, and okay, but I want to know who's in your life. you know, reading and listen, I did not read enough books. And I have started to read more. And I guess I felt like because I have so many Black people in my life and Asian people and people of color in my life, that I didn't need to necessarily read books. I'm not a big reader anyway to begin with, but during this whole thing, I said, I need to read more, and I need to dive more into the academia of racism, right? Because that's something I have never delved into. But one of my biggest criticisms of white people during this whole thing is like, okay, so you're posting, okay, so you're marching, that's all great. And I don't want to criticize that, but who are you eating dinner with? And who are you going out with? And who are your friends? Because I know who your friends are, because I see you. I see you, I see you, I see you, and I see you. And I know who your friends are. But again, I don't want to call people out because that's not productive. But it is a really valid point. There's not, you know, who are your friends is my question to people that I have not asked. I have not asked that to my white friends.
But that's in the healthcare industry too. They're posting blackout posts. They're talking about, oh, Black Lives Matter. They're sending emails asking us, what about Juneteenth and all of that? But then when we bring it up at the nurses station, you got an issue and we call it into HR. You got to pick a struggle. You got to pick
I know.
Well, I think it's for us, and then but don't talk about it. It's the same thing. It's a lot of people that I know that the only post that I see on their page is that Blackout Tuesday post. Sis, that was months ago. Like, what you want to say?
There's more work that needs to be done. The work is not as simple as 8 weeks of protests and Instagram.
I know.
We have to work every day. We have to be uncomfortable. And
that's the thing. I feel like a lot of the issues like we're talking about now are issues that as Black folks we've always been talking about, right? Like there's this meme on Twitter, like Black folks are all like now like per my last email ... Like we literally have been talking about this, right? But I'm hoping in this moment, right? Like I feel like we're at an inflection point, and it pains me that it had to take basically this global pandemic where like the social contract, especially in this country, between our leadership and the people has totally been broken, right? Like no one's taking care of us, right? We're basically fending for ourselves. And I think everyone, not just Black people probably felt like that before, but I think everyone is feeling like that right now. And then to see a Black man murdered so violently and just horrifically on video by this police officer, right? To see that, I think that really shook a lot of people that haven't been shook before. And so I think that, you know, I'm glad that we're having this conversation. I hope that this momentum keeps on for a while, because I also feel like this is an opportunity for Black folks to speak up. It's almost like we have permission now. You know, we've been saying it, but now like we actually have the permission to speak up, because we're like, see, this is what we've been saying all this time.
And I think that it goes as far as the whole, like, okay, for instance, when we hear them on the news saying, oh yeah, Black people are getting COVID-19 more and they're more affected by COVID-19. But pause, when nurses were getting COVID-19, you said nurses were getting COVID-19, but then all of a sudden when Black people are, you don't say essential workers, you say Black people. You know what I mean? Like, no, we're getting more sick because we're essential workers. It's the same thing as how we talk about, when we talked about how Black people were getting more sick, it wasn't like, oh, these are the reasons why they're getting more sick. It was no, because of their dietary restrictions. No.
Right.
We really need to stop acting like fried chicken has different nutrition than pasta. It's the same. Like, we are 12% of the population. If we're the only ones eating unhealthy, then Taco Bell and KFC would not even be in business. So we need to stop acting like that's something that we could just keep walking over. The health disparities in this country are now, it's a disease. It is killing people. So we need to stop walking over and pretend like it doesn't exist to make everyone comfortable. So don't say, oh yeah, Black people are more at risk because of their diet. No. It's not just diet. It's not just anything. It is systemic oppression and racism in this country that is killing Black people daily, period.
Yeah. Let's talk about nutrition in hospitals, shall we? Some other time, but let's address that at some point.
Yes.
Yeah.
Yes, and that's serious because we don't talk about that. We don't talk about that. When you have a young woman who says, "I want to talk about my diet" or "I want to be vegan," it's shushed off, you know. So all those things matter as well, as far as how people are treated, how they're listened to. And I think this is a perfect segue into the conversation about how us as Black people feel when we do not have providers that look like us. I know for me, when I went to the GYN, I never felt comfortable until I went to a GYN office where there were people that looked like me. But I think also, even when I had the white nurse practitioner see me, just having that Black woman on that staff made me feel better. And to me, it changed their open-mindedness to how they treated me. So I just want to, bring that in, maybe Tamisha,
Yeah.
about that, or just about how does it feel? How, when patients see you, I know they'd be like, "Oh, you're the doctor," and I'm sure you get it all the time because I get it too. So I just want to tap into that. Anybody that, wants to tap into that.
Like, especially as like a medical student, like I'll never forget, like, earlier on one of my rotations, like, I'd introduced myself, I went in first and they were like, "Oh, you're taking care of us. Oh my gosh, you're great." And then by the time my supervisor came in, who was also assessing me, they were like, "She was amazing. She asked about all the conditions. She even asked about all the times my baby had used the bathroom, like got all the recommendations food-wise. She's awesome." And it's like, that kind of like going the extra mile to kind of like talk you up to, like, who you are, who you're being evaluated by, I think is kind of like really important. I've gotten so many, "I'm so proud of you, like you're almost there." So I think it honestly really, really does matter. And I think even like having that position, even though like as a med student, I'm obviously like still kind of at the bottom of the hierarchy, to be like, whenever there's something that's a little bit kind of not going right with the patient, I'm kind of like, "Are we sure we really think that in terms of a differential diagnosis, could we kind of broaden this a little bit? I'm not sure that that person actually has antisocial personality disorder. I actually think they have complex PTSD."
But to me, Shay, but even like your role as a medical student is to be you're a patient's advocate, right? So that's why I see, like, even you as a medical student, it's so important for you to be there, even especially for your Black patients, right? To speak up for them.
Thank you. And sorry, I just said something and I didn't explain. Dr. Cyrus probably knows what I'm talking about, but I think in psychiatry in particular, there's kind of this pathology applied to Black people that's not congruent with what's applied to white people. So for example, white people are more likely to be diagnosed with, depression and anxiety disorders. However, Black people are more likely to be diagnosed with, schizophrenia and other psychotic disorders. So I had an experience where I had a patient come in and he had a very, very traumatic life. He'd been in prison. He'd witnessed a family member be killed in front of him. And since he'd spent all this time in and out of prison, kind of how we discussed the patient and, how his face looked, or what's called his affect, and how he related to people, a diagnosis that was floated around was that he has antisocial personality disorder, which is basically this pathology where you have no regard for other people, you break the law. There's been some evidence of this since before you were 15, versus, white patients who might more likely be categorized as having, post-traumatic stress disorder. So these diagnoses actually matter because, for example, for an antisocial personality disorder, especially hospital-wise, there's no real treatment for that. So there's no indication for hospitalization. So this patient was discharged. However, if you have a PTSD diagnosis, there's sometimes, anti-anxiety drugs or different medications that you can take, and therapy, you're eligible for that. But because you're relegated to a specific diagnosis, like, you don't get the help you need. And Dr. Cyrus, please jump in and talk if I messed anything up. But
no, you literally did a great explanation of it. And I think what you're saying, you're essentially citing the research that says that Black people get diagnosed, they can present with the same symptoms and get misdiagnosed, which is why we don't trust the system. So in addition to, I think what Uche was talking about earlier with Tuskegee, with experimentation and OB-GYN, right? Is that why do we trust the medical system? And I can't say, and I'm a bit of a cynic when it comes to this, and I don't know that we always should trust our doctors in the system. I mean, I essentially was educated. My mother I always think about my mother. when I kind of think about these kinds of things. My mother is like born in the 50s, originally grew up in rural South Carolina. I was raised, don't trust white people, don't trust white doctors, right? There are times when my family has not sought care because they don't trust the doctor and the medical system. And sometimes, like, to see some of this actually happen and know that the statistics do show that when there is race concordance, that outcome, at least patient satisfaction is better, right? There's some research out there that actually shows folks who are most skeptical of the system end up seeing a Black doctor, that they end up benefiting the most, like net positive more in terms of reduction of negative outcomes. And I think about this, like, there's no way that the likelihood of finding a psychiatrist who's Black, if you're a Black person, is slim to none. So, like, what are we gonna do if we're not actually gonna be able to match by race, right, Sheena? Which is why I think I get a little depressed and sad about these statistics, because, like, I don't know that the system will ever adapt so that you do have matching, right? So it's like, that is the optimal solution, but that's not actually what's gonna happen. So what are we gonna do with the doctors we are training? Like, what are we doing with the supply we do have? And we're not doing enough.
Well, can I just mention, I just wanted to mention, so I had taken care of patients during COVID here in New York City, and I had a number of patients, older Black man who I said, I wanted to send for my urgent care to the hospital to the ER because his oxygen was low. And he looked at me and said, he was like, baby girl, I'm not going because they're not going to take care of me, because they don't take care of us. I had another patient, a younger Black woman who was diagnosed with COVID, come in because she was still having shortness of breath. And I had layers of like personal protective equipment on. And she looked closely and she's like, are you Black? And I said, yeah. And she said, okay, good, because I know you're going to listen to me. Right. So this is what, these are what our community members are going through. Can you imagine? You just want to go get taken care of, but then you are worrying about, can you trust the provider or not, right? So it's so deep. So much work needs to be done. And it's not just about increasing the number of Black healthcare workers, but also, teaching white physicians, how do you care for Black patients, right?
And
that's
Black people don't have higher pain tolerances.
Right. Still on that, because we're still on that somehow, 2020.
Right.
And I just think that, like, you guys definitely explain that so well, and I appreciate that. I just also want to tap into the more surface level of when I go into patient's charts and I see patient aggressive, patient combative, patient irritable, patient non-cooperative with care, patient non-compliant, pause. Then I go in the room and it is, patient is perfectly fine, nice to me, no issues, takes all their medications. So, and the patients constantly say, what Uche said, oh, thank God you're here, or oh, thank God. And I've had this happen multiple times because I deal with a lot of sickle cellers and I deal with a lot of CFers, hand in hand, way too different treatment. And sorry, cystic fibrosis patients are primarily young white people, and sickle cell patients are primarily young Black people. And there's a huge difference on how the two populations are treated, complete two different illnesses, not saying that they're similar, but just in the sense of how people are treated. And I actually took care of one of the million Black CFers, and that's very uncommon.
That's
and
rare.
Yeah, and a beautiful spirit. And she reached out to me so many times, like kind of like telling me, like, even like as I was on the floor, like, can you be my nurse? Can you be my nurse? Because people didn't understand the average CFer is they live with their parents. They're typically, even when they're 20-something years old, depending on how sick they are, they're typically more catered to by their parents, understandably so. They come in with their parents, they decorate the room as teddy bears. That's how their illness kind of presents, whereas the Black CFer comes in, she got a job. Every time she come in here, she got to quit her job. She about to lose her apartment. She doesn't have the same support system as these other people do. Right. So when you go into her room and you deem her as non-compliant or irritable or aggressive, just because she has a chest tube and she doesn't want to be bothered because she's tired and you guys aren't giving her adequate pain medicine, then here's the problem. Because now you're not going in her room. Now you're not addressing her pain. Now you've ruled her out as the difficult patient on the floor, so no one wants to have her. So it goes hand in hand, even beyond actual psychological issues. It also is like, Why are you reporting Black people's normal affects as an issue for you? And why is that in the chart? Why are you giving that in report? Like, we need to really cut down on.
And the chart is a legal record. Like, it stays with the patient. Right.
Like, because you're not used to my affect doesn't mean that it's abnormal. You need more Black people around you. It's not a me problem. It's a you problem, baby.
Yes.
Well, what's interesting is that you mentioned patients with sickle cell disease and patients with cystic fibrosis, and you're talking even just about how they're treated, but even thinking about research and development. Do you know how many funds and resources have gone to cystic fibrosis treatment? There are centers literally all around the country for cystic fibrosis. For sickle cell, there are 1 or 2 centers. There's 1 or 2 drugs for sickle cell disease, and there are at least 20 or 30 for CF. So it's as if, starting from the beginning, Black patients have the cards stacked against them in terms of how they're treated by clinicians, in terms of what's available for the diseases that may be genetic, based on geographical ancestry. Yeah.
Yeah, and even I'll give you one better. Why is it that we have IV infusion centers for chronic regional pain syndrome that is? Do y'all want me to go there? I just want to know, did y'all have some type of insight? Because there's this thing called CRPS that is a disease that is I don't know how to say it properly, but it's somewhat word of mouth. It's the patient telling the physician something and they diagnose them with that. There are pain centers all around the country where we throw the whole kitchen sink of narcotics at them, to the point where sometimes they are in the ICU because that's how heavily we medicate them with ketamine, Dilaudid, Benadryl, Ativan, the whole entire kitchen sink. But when a sickle celler comes in, which has a known diagnosis of pain from birth, they have to fight to get 2 milligrams of Dilaudid, which is treatment.
Right.
So why don't we have pain centers for sickle cellers? Why do they have to be in the hospital for days at a time? Why? Right. Why do we have meth clinics, but we don't have sickle cell clinics where they can go and get their medication and not lose their jobs from being in a hospital for days? I'm gonna just leave that right there.
Why are there studies that show that medical students believe that Black people have higher pain tolerance?
Yes, I was just about,
and then therefore do not prescribe appropriate pain treatment. And we know this. This is like an old study from 2006.
Yeah,
and I just want to make this known. What we are saying is fact. These are not theories. These are not opinions. These are not thoughts. These are facts based on evidence and based on history and years of evidence that's been put together. Just throwing that out there.
Yeah, I think the most frustrating part, thank you, Dr. Cyrus, for mentioning that study. The AAMC actually just republished it. You hear a lot of times that, it's just the older doctors that have practiced XYZ thing. And it's like, okay, who are the older doctors going away and not training the newer doctors? Like, is there a new system that's coming in to stop these ideologies from being passed down? But no, a lot of even like medical education as it stands is very hierarchical and traditional, and a lot of it hasn't changed. So you can't expect systemic change to happen if you just keep teaching people the same thing. Except you mentioned, there's a new drug now, but the same fundamental teaching is the same.
Yeah, and everything has to change. Everything has to change.
Yeah,
that's how I feel.
Something, Sheena, you mentioned actually we'd all been talking about it, but kind of how our affect is ruled aggressive. It starts from birth. Like I earlier on in my clinical rotations, I was in the neonatal nursery, and this baby literally was just born 3 hours ago, like a fresh baby. And, we'd been going around, and the newborn exam is the thing that you do. And it's actually kind of a bit of a violent exam. You're trying to check if the hips are dislocated. So you're pushing them, you're pulling them. So long story short, the babies are not really going to be happy, especially if they were sleeping already, but you really do need to check to make sure there's no hip issues. But so I've been going around, with my team, and, we'd examine some white babies, we'd examine some Asian babies, and we'd examine some, babies of other races, and the discussion there was, normal exam, no hip dysplasia, this, that. But the second we got to a Black baby who had literally been born 3 hours ago, all of a sudden the discussion was that the baby was irritable. The baby did not tolerate the exam.
3 hours old?
Yeah, look, I
tolerate the exam. A 3-hour-old baby didn't tolerate it.
I was actually, it was sad because I was shocked, but then I was shocked that I was shocked.
But to me, Shay, were you like, that baby is fine? Were you like, that baby is fine?
The baby was absolutely fine. And obviously, like, I don't have my MD yet, but I've done enough newborn exams at this point. That baby was no different than any of the babies.
So we got a new terminology, angry Black infant now?
Literally, and it goes into the newborn exam, irritable on exam.
Wow.
So
Who gets to write that? Who gets to write that? And do you have an opportunity? Do you feel like you can say something in that moment or no? Because
in that moment, it depends if it's the attending saying it versus the resident, but in both cases, you're kind of, I kind of offered kind of a soft pushback, like, oh no, we just woke him up, so he's probably just a little not happy with us that we're doing it after he was woken up. So that was my kind of get around that, but in the back of my head, I'm like, you have got to be kidding me. Yeah. Like, but in that sense, like, if the physician is the one who's writing the note or is attesting a resident note, that's the official language that goes in. And that ends up having actually quite material consequences beyond just being point racist.
And it leads the nurses, because that's what we see, and that's what we go by.
It's a downstream effect.
And then you start thinking, oh, is this baby all of a sudden, is the baby in opiate withdrawal? Like, was the mother like a drug addict? Like, all these things are triggered by baby is irritable.
Meanwhile, the baby just cold. You uncovered her.
Or the baby is just a baby. It's crying.
The baby's in a nice little warm womb for 9 months. And all of a sudden, like, in a cold environment, it's like, what's happening?
Yeah. Ellen, you had asked a question about, could you say anything? And this, and I think this is also a thing that is really demoralizing. I know, especially when I was sort of going through, I call my year of little T trauma at Yale, was how you see the paralyzation in everyone else who should be, if we're going to use the word allies, but your community, people are afraid to speak up. Like, there were so many things that would happen. I'd be in meetings and I would end up saying something. It's almost worse if you know that you're someone who's outspoken because you're going to say it. But I would come out of a meeting, people be like, I'm so glad you said that. And it's like something that we would have agreed on beforehand. It's like, well, why didn't you say anything?
Right.
I do this workshop where we train doctors how to respond to harassment, and we train usually attending doctors. And the biggest, like, we did a survey of all the students at Yale, and a lot of shows that, like 60% or something of trainees experience some sort of harassment, either racially or gender. And the biggest complaint was that their supervisors don't step in. So what happens when you have a patient who calls you the N-word or does something sexually harasses you? And so many of these doctors have no idea what to do. It's almost like the I don't want to say the hierarchy is paralyzing in this way that you don't even feel safe saying anything, but some of it is that we're not trained to actually know how to say anything. But I can't tell you enough, like, how there's not a culture of speaking up. And so if you are one of the 2% of Black female physicians, right, and someone doesn't look like you, how do you expect anyone to have your back? And the way I bring this up for a reason is that I was actually saying to my therapist this morning that I joke that, I used to be a very social, extroverted person, and I've sort of become like a little bit agoraphobic in this way that I don't go in big groups anymore. I'm very careful about who I go out in public with in terms of my friends. I had so many experiences of feeling unsafe socially. And so it's all connected in this way mentally of, like, when you don't feel like anyone is going to speak up for you. And it happens so much professionally. And then now with the world the way it is socially, it's highlighted even more. But it takes its toll on you emotionally. And this is why you see rates of infant mortality and rates of death after giving birth and cardiovascular risk of women in their 50s and 60s, right? Black women. It all impacts you in this way that I think it's like an invisible toll that just kind of hits you.
Well, there's a word for that, the weathering effect. There's a phenomenon that's been described where, because of this chronic stress of dealing with racism, it actually has a physiological effect on gene expression, on telomeres, parts of the DNA. Like when you look at DNA from Black people, we have aged more than a white person of the same age, like on like a molecular level, because of the stress of racism. So while race itself is a social construct and is not biological, dealing with racism and the stress of racism, influences even gene expression. That's one of the reasons why it's thought that Black Americans have a higher rate of diabetes, because the stress actually affects the insulin gene, right? And so, I mean, to think about, and that can be passed on across generations. Even the high infant mortality rate is actually thought to be connected to slavery. The stress that mothers in slavery endured, it has been implicated in why we have a high Black infant mortality rate, one of the reasons.
Yeah.
So, I mean, it's just, the fact that stress can have like these physiological changes on a human being is just so incredibly profound to me.
Yeah. And that we're going to look like we're getting through this journey, which sort of is like the first question I know Ellen asks, like, how do you get to the end of the journey? And it's like, we're going to get through it. You don't know that I'm like, a crazy neurotic person underneath this, because I have in control, right? Until I tell you. But it's like, we're going to get through this. And in the meantime, we suffer. And it's, that's, I think, the greatest challenge of probably.
I know.
And I think that I think what the bigger picture is that we're also so used to having to be this way that we don't even know that it's trauma. There's so many times that I have been through something at work, and not even just like this. I've worked at multiple institutions, not just the one that I'm at, but so many times that I went through something at work and the Black nurses would say, well, you can't say nothing because then they're going to write you up. You can't say nothing because then they're going to find a way to fire you. And you don't even realize how much trauma is in that statement. The fact that I cannot talk about someone harassing me or being abusive to me, all because of what I'm going to say. And it, I don't know about y'all, but I had days where I had literal chest pain from how much the weight, not even just like George Floyd and seeing that, but then also going into work knowing that half of you feel the same way, and I have to work around you, and knowing that you're treating Black people, knowing that you don't even like us. You know what I mean? There's plenty of places in this country where people can work if they don't like Black people, but yet they still come to the inner city hospitals and run amok. What are you doing? And it just, when it comes
up, we know why. They're probably, less likely to be sued. They probably,
it's just horrible, and it is heartbreaking. And I think that the people don't realize the toll that it takes on you. Like Dr. Cyrus said, you end up, because I'm a very bubbly person. Everybody that knows me sees that. I'm all over the place. I'm happy. I'm all over it. But there's times when I'm in that little cubby on the side of the unit, and they're like, are you okay? Are you okay? No. I am not okay. I'm sick of y'all. Leave me alone. You know what I mean? You have those days where you feel like you literally are in a cocoon. You cannot be yourself, because if I talk, you're going to say I'm aggressive. If I say this, it's going to bother you. If I speak up about my patient, you're going to write an email to your director. It's Karens amongst doctors and nurses. There's Karens amongst management. It doesn't stop. It's Karens that are CNAs. And one thing that I just want to make sure that we point out here is that the system works entirely too well for it to be one piece. This situation is not just doctors, it's not just nurses, it's not just CNAs, it's everyone. It's not just Black, it's not just white. Everyone is included. And the bigger picture here is that everyone wants to stand behind, I'm a good person, it doesn't apply to me. No, I'm good. I would never do that. All of us need to self-reflect. You're not a good person just because you deem yourself one. Good people actually do good things. So take a minute to self-reflect and think about, how can I be anti-racist? Even as Black people, how can I make sure that every patient is treated with the same quality of care? Period. And everyone should self-reflect that. And that doesn't matter what race, how long you've been a nurse, what you think about yourself. People clearly think whatever they want about themselves. That doesn't mean that it's actually true.
Yeah.
And that's back to my comment to Dr. Fawale, which, and I didn't mean to imply, my question came as, were you able to speak up, right? So then I had to ask myself, yeah, it's on her. Like, she's the one who's expected to speak up, because
Right.
as a student, you know, in a learning environment, can you take an opportunity to say, hey, you know, can you do the teaching?
Right.
You know, sorry, I'm pounding on the table. Um, can you take that opportunity in a teaching moment to do the teaching? And I think this is probably, you know, my biggest comment to all the Karens and all the white people who want to be allies is, this is your moment. It's not just about reading books, and it's not just about Instagram. When you see these moments happening day in and day out, minute after minute, hour after hour, please, I am begging you, no matter how uncomfortable you are, no matter how afraid you might be about retaliation, it is our obligation to speak up and to say something. So Dr. Falwale is not the one who has to say something, because Black people have enough to deal with. We have created this problem. We have to be the ones to try to work at dismantling it, because there's enough on the plates of Black people in healthcare. So if you are watching this and you are a white person in healthcare, a man, a woman, a nurse, a doctor, it is your obligation as a human being, for the sanctity and well-being of the patients, of your doctors, of your nurses, to speak up and say something. This is going to take everybody to get into this fight and open your mouth and say something. Word it however you want. If you don't want to upset people, listen, I have news. People are going to have to be upset. It's the only way. And you know what? If you do it with love, come from a place. I've been in plenty of situations, in work situations, and I just make myself small in some situations, and in some situations, if I'm heated, I make myself bigger. But I say, this isn't cool. This isn't okay. I'm sorry if this makes you uncomfortable, but this is the right thing to do. And at the end of the day, my heart says, if you're doing the right thing, if you're doing this for the right reasons, I'm sorry if you're mad, but you have to understand that I'm doing this because it's the right thing to do. It's the human thing to do. So just lead with that. Say to yourself, this is the right thing to do for me to speak up and be selfless right now. And she's more important. Dr. Frawale is more important in this moment than I am, because guess what? You're white. You're going to be okay. You'll get a pass. She may not. She may get retaliated against if she speaks up. You will not. Trust and believe that. So please, that's it. Just speak up. Use your voices.
But you made a good point, is that it's about comfortability. And when it comes down to it, people are dying. So sorry if you got to be uncomfortable for a minute.
Right.
I would rather this person live than you just get a little, itch that you can't scratch. Like, good. Like, okay. Like, that's not even nearly as important as these pregnant women that are going into the hospital happy as can be to come home with the baby and dying in childbirth for no apparent reason. Like, this needs to be discussed, no matter how uncomfortable it makes anyone. And it has to be discussed from the root, and it can't include the 2% of Black female physicians. That's not enough. It has to be all the female physicians say, we're not doing this no more.
And if your coworkers, sorry to interrupt you, if your coworkers feel safe and feel better, you have more support. You have a better team. You have a better support system around you if your coworkers aren't stressed and feeling unheard and feeling unseen. It works. It's just a win-win for everybody.
Mental health 101.
Yeah.
Yeah. Cyrus, yeah. Mental health. Yes.
Yeah, I think it's all about everybody just having everyone else on their mind. And like, I forget who said something about I think it was Dr. Blackstock said about being intentional. We cannot just keep on just living our lives, that time is over. It's 2020. It's aliens about to come too. Like, we got to get it together. We have to, I'm just being real. 2020 ain't
I know.
Games. We have to be very intentional about everything, the ozone, everything, because we are literally killing ourselves and our planet by just being laissez-faire about life. We cannot anymore. We have to be very intentional about the way we live, the way that we treat each other. And we need to make racist people, evil people, killers, all those people the minority, and make good human beings that want to love and protect one another the majority. And then we'd be all right.
Yeah,
Yeah.
there's a phrase I learned a couple of years ago, which is probably, I don't know if it's more popular now, but separating intent versus impact. And I think that it's so, even if, so not just we have to live intentionally, but it's also being humble, because there's so many things that we don't intend to do, yet the impact is harmful, which I think goes back to like what Alan's saying, is that if you know your coworkers are safe, if you are trying to reduce like the harm that you put into the universe, you know that's a better situation, but you also have to acknowledge when you don't intend to do something that harms other people, right? So it's not like, I use this analogy in my talks, like if you step on my foot, it's more than likely an accident that you didn't intend to step on my foot, but you stepped on my foot, it still hurts. You're going to say sorry, right? I'm going to ask you to say sorry. And racism and these dynamics are the same way. It's just really hard to talk about that impact because we as humans are anti-confrontational. It means that like, oh my God, you've attacked my character. It's like the end of the world. No, conflict is actually good for you. It's psychologically, right? It's good for you to get into conflict, not to get intentionally into conflict with someone, but after you have conflict to actually work through it, right? Like that's how this all works. That's how you know that bonds can actually sustain it, is when you actually, you do that. So I think sometimes we may think that like Tanisha is going to be the one to say something because she always does, but it doesn't necessarily mean that that's the thing that she should be doing all the time. Everyone needs to be practicing this.
Right. And I would add that, I just wanted to say that, and I think that white people in particular have to step out of that comfort, right? So what this is going to require is discomfort, because as Sheena said, we have people dying in the streets, being killed by police officers. We have Black mothers dying when they go into the hospital to deliver their babies. So we are literally we are in crisis right now, right? So if you're not going to do it now, then when? Right? It has to be now. This is the time.
And someone said, I'm sorry, go ahead, Ellen.
Sorry. As a white person, yes, you are going to make mistakes. I've made plenty of mistakes. I've said plenty of things that people found offensive. I've said things that I didn't even realize were offensive. And we all make mistakes, and we're going to make mistakes. But if you come from a place of wanting to do the right thing and wanting to be a human being, just make the mistake, learn from it, and keep it pushing. You're still going to be standing. There's not going to be, as a white person, there's never going to be any cop's knee on your neck for stepping out and saying something wrong. If your intention is good, then just try to learn from the moment and push through it. And that's a mistake you'll never make again.
Yeah.
Hopefully.
And I want to leave us off with one thing that I saw on Instagram recently. Is someone made this meme that said, if you ever wondered what you would do or what side you would be on in the Holocaust or slavery rights movement, here we are. So these people that said, oh, I would have done this and I would have helped people on the Underground Railroad and I would have did this and the third. Here's your time, sis. We've been waiting.
Right.
So at any point in time that you want to step up and say something, or this is an active thing, instead of pointing fingers, think about what you can do. And instead of, thinking about how this inconveniences you, think about how you can brush this process along, because it's going to happen. We're going to keep applying pressure. So we thank you guys so much for.
I just want to say one thing also, Sheena, you just made me think of something, because, a lot of people say to me that, well, you're in a position to be able to use your voice and you're in a position to be able to speak up. And and that's true. I'm very lucky and I have a lot of gratitude that I am in a place in my life where I can speak up and use my voice. But that's not a good excuse. That's not a good enough excuse for other people who don't have as much power to speak up. Because I will tell you this, when you start speaking, because I'm 50 years old. I didn't always speak up. I didn't always use my voice. This is a process. I learned to be comfortable using my voice. And I got empowered by using my voice. So even if you think your voice doesn't matter, or you're another white medical student alongside of Dr. Fawale, and you think you can't speak up, you're gonna be so blown away by how strong and powerful you feel by taking that risk and by speaking up. And the next time you speak up, it's gonna be even easier. And so on and so on. The more you speak up, the easier it's going to get. Doesn't mean you won't mess up. You may still mess up, but you will gain confidence and strength and believe in yourself the more you do it. So I encourage you all to start speaking up for your coworkers, because like I said, it's a win-win for everybody. You will get better at it, and you will be empowered more than you can imagine by doing it.
Your coworkers will be blown away and so grateful. And I think that, that's what we all have to understand, is that we're all human. We don't expect for white people to turn around tomorrow and be educated on everything that is so-called Black. But I do think
that would be nice.
But it's just a principle that we just want you to care. We want you to think. We have to work beside you.
Or consider us human beings, right? Like we're human. We're just like you, right?
You can tell.
I have to say, they're not just like you. They're way smarter. This collective creators, like IQ's off the charts. So slow down with that, Dr. Blackstock.
Right, like you're exempt. Like come on. But seriously, I think that we just have to remember that. Like, nobody is perfect. So someone is on this panel and they feel like, oh, well, how do you do that? I'm scared to say the wrong thing. Oh my God. No. Like, no one is perfect. We don't need you to be perfect. We just need you to show that humanity and show that you do the same for you. So we appreciate you guys so much.
Thank you so much for this. Thank you, Sheena. Thank you, Ellen.
Dr. Fawale, Dr. Cyrus, Dr. Blackstock, thank you so much. They're all so busy. They're such busy women. Sheena, you're so busy too. And to gather all of you together and give me your time, give us your time to start these conversations is really meaningful to me. And I am in awe of all of you. And I'm really happy to meet you. And I thank you from the bottom of my heart for opening up and talking about these issues.
Thank you.
Thank you. Your reach will help our stories get told. So we appreciate you.
Yes.
This is great work.
Yes. Keep using your platform, Ellen.
Yeah, and I was watching you during a talk, and there were so many times where you were like, "Oh," glad you. You can tell when people are passionate about things, so it's nice to see it.
You guys, I have to go. My little ones are in the other room.
Yeah, thank you.
Thank you, guys.
Okay, everybody. Bye-bye.
All right, have a good day. Thank you.
Bye.
Thank you. Bye-bye.